Good morning, everybody. I am very pleased to be in this forum to speak about ADPKD and children, and to share with you the opinion of the pediatric nephrology world. My presentation starts with a big thank for Tess and for organizing this amazing day, because I really believe that the patient have a very important role in PKD awareness, but also in improving the care of the disease and pushing the research further. And I think that Tess did already a huge work, and it is a big place in the PKD research world to have her. So I am the third speaker, and I will actually benefit from all what my colleague Rosa and Emilie have told you. However, I would like to go back to some definitions, and I would like to highlight that ADPKD is 1 in 1,000 live birth, and there are more than 12 million patients worldwide. A normal kidney weight is about 150 grams and about 11 to 12 centimeters. With the growing cyst formation, a kidney might actually weigh almost 3 kilograms. So the two kidneys together are 6 kilograms and might reach even 30 centimeters of length. So it is also very important to mention that it is one of the most hereditary kidney disease and the 4th common cause of renal replacement therapy. And the genetic part has been already very well explained by Emilie. So it is also by Emilie explained that ADPKD is an autosomal dominant disease, where actually each child have 50% chance to inherit the disease. However, I would like to highlight a second point here, where sometimes there is a confusion in patients that is not because the first patient or the first child inherit the disease that the second one do not. So each pregnancy and each child have 1 in 2 chance to inherit the disease. And some patients have this confusion, and they ask me for this. So I think that Rosa and Emilie introduced my talk very well, as they were and they made the statement that we should not test children in families with positive history of ADPKD when they are asymptomatic. And actually they opened the door for me, because it is a very important medical controversy which divides a lot of doctors about this question. And why it is a controversy? Indeed, so like Emilie and Rosa mentioned, we don't need to test asymptomatic children because we don't have an effective treatment now. They will have some problem with their work or insurance, and we will stress family by medicalizing their asymptomatic child. However, the doctors who are more pro to test the asymptomatic children are thinking that we might detect some aspects that we might treat and we might influence the long-term follow-up. Sometimes it is also seen that some very severe childhood disease have a high recurrence risk. And last but not least, but sometimes, and what I am seeing in my clinic, that some parents are very stressed because they are not knowing if they have passed their disease or not. And testing might take out this stress. So, as it was showed by Torres, it is indeed an ADPKD where mainly the patient reach end-stage renal disease at a late age, about 40, 50, 60 years. And this adult onset is very well known, although it is clear that the first cyst starts already in childhood or even in utero. What I would like to highlight today is that ADPKD have a very high variable phenotype. And we are seeing in our clinic some ADPKD children with a childhood onset or even with a very early onset of ADPKD. I need to be clear, these form of ADPKD are very rare and they are not yet very well studied. So the past 10 years, there is really a change of thoughts, and the ADPKD presentation are really getting over the entire age range, and we are seeing a lot of children in our pediatric nephrology clinics. So the pediatric community is really very active and trying to define what should we do with these children and how can we counsel these families. So it is a challenge for us to get this balance between not medicalizing these patients, however, going for screening these modifiable comorbidities. So we think that the last year we have changed the picture in ADPKD, and it is more and more becoming a pediatric disorder. Recently, when we organized a day in Leuven in Belgium, where also Tess Harris participated as a patient, we had lots of international experts getting from pediatric nephrologists, adult nephrologists, geneticists, and radiologists, and we wrote all together an international consensus where we actually discussed very balanced the controversy between testing or not the children with ADPKD. And recently, with Charlotte and Carson Bergman, we wrote a very nice review with the wind of change in the management of these children, and I will go later through our proposal. So I must mention, what are we seeing in our clinic? So the patients or the children with ADPKD are presenting really with a broad diagnostic spectrum. Or we are seeing them, or they are presenting to our emergency room because of really symptoms of bleeding. A child who is doing sport, he have a trauma, he gets macroscopic hematuria, they end up to the emergency, we do an ultrasound, we see cyst, and it appears that there is a familial history of ADPKD. What we are now also more and more seeing is the prenatal diagnosis and prenatal detection of already renal manifestation in a known familial history. Also, we are seeing a patient who presenting with proteinuria or hypertension, and they don't know yet that they have this disease, but seeing them, we will actually make their diagnosis. The second group that we are confronting with is what we call the unintentional diagnosis. It means that a patient have another problem, come to the emergency because of appendicitis or because of abdominal pain. We do an ultrasound for another symptom, and we discover the renal cyst. So the patient will know that he have inherited the ADPKD from one of these parents. And the third group is really the intentional diagnosis of a complete asymptomatic child, where families are coming to our clinic and asking really for getting this screening done. So I must highlight that childhood and childhood ADPKD is also associated with, like we see in adults, with actually urinary tract infection. This have a decreased urinary concentrating ability, and sometimes we are seeing them in the clinic because of bed wetting. Sometimes they show up with hematuria, very, very rare, sometimes with pain because of cyst hemorrhage. Some adolescents are presenting with abdominal or back pain. I must say, in opposite to the adult ADPKD, extra-renal manifestation like liver cyst or intracranial aneurysm are really, really very rare, and we don't go in this in depth in this presentation. However, I would like to highlight very high that proteinuria is present in 20% of the children, and most importantly is that more than 20 to 35% of the children have already hypertension. And this hypertension is also associated with heart, with left ventricle heart hypertrophy. And sometimes we see also that there is actually an increase of renal cyst and kidney volume in this population. There is a very nice study published on in a European cohort of 310 children. And we actually demonstrated that indeed 35% of ADPKD patients have hypertension. What was very interesting to demonstrate is that 52% of these children don't have a nocturnal dipping, because normally when we sleep, our blood pressure and heart rate will decrease, what we call the dipping. But in ADPKD, 1 in 2 children are not having this normal dipping pattern at the night. So this study was really very important in our community, as we are very alert in children at risk for chronic kidney disease, for all the renal diseases, also not only from ADPKD. And we try really to keep the blood pressure under the percentile 50, because it has a lot of benefit in long-term cardiovascular, but also in the renal outcome. So, as I mentioned before, based on the international consensus statement paper, and we wrote with Charlotte and Carson a review, and we tried to summarize actually all the pediatric phenotype, and tried to make actually an algorithm that pediatric nephrologists might follow to help standardizing the management of these children. So as I mentioned, our child is coming to our clinic because we have made the diagnosis of ADPKD incidentally, or with a presenting symptom like hematuria or hypertension, or we detected the renal cyst prenatally. So when we see these children in our clinic, the first thing is, of course, to investigate the familial history, or is the disease known in the parents, or we will perform an ultrasound in parents or grandparents if the parents are younger than 40 years of age. If there is a positive familial history, then the diagnosis of ADPKD is already made, and we will recommend a regular follow-up, and I will come back to this later. If there is a negative familial history and there is a negative ultrasound in both parents, so we recommend another workup of cystic kidney disease with the genetic counseling. What about the asymptomatic children with a positive familial history? We are really confronted with parents who are coming to our clinic and who ask for it. And there I am really against to give a conclusion to the parents without explaining everything. And I think the adult nephrologists do not have the right to take the decision instead of discussing the possibility with the families. So I would recommend actually to discuss indeed the work insurance issue, which is for several countries not a problem at all. However, when this is very important, I think that the family need really to know what are the consequences of testing. Further, when the child is really mature and old enough to understand, I think that we should take him in account and we should discuss with him all the consequences of making the diagnosis. Then we give them the choice, or to defer diagnostic screening, to wait and to see, and to discuss this when the child is adult. However, do not forget to go back and to discuss with him when he becomes adult, and don't discharge him. We will recommend in this population to screen for blood pressure and for proteinuria without unraveling the diagnosis. When the family will choose for diagnostic screening, then we have two options. Or we do an ultrasound. However, this ultrasound might be negative and will not exclude the disease. Or we go for genetic testing, and or we make the diagnosis, or we exclude the diagnosis, and then we discharge completely the child from the clinic. What are we actually recommending for the follow-up of these asymptomatic or symptomatic children is to do a yearly or every 1 to 3 years a blood pressure measure and urinary protein excretion measure. And we actually advise really lifestyle change, like lower dietary salt, do sport, do not smoke. We are very alert in BMI, and it has been shown that BMI, that a high BMI and obesity is correlated with hypertension and correlated also with a rapid progression of chronic kidney disease. To avoid nephrotoxic medication, and for the adolescent, we already make them aware that they need to have estrogen-free contraception. And there, if you are more interested to read about it, I would recommend to upload the PKD International route map. And it is also translated in several languages, and you can read more about all this lifestyle advice. So what about tolvaptan? I think that Rosa already explained to you very well the value of tolvaptan in adults. However, we were actually interested to look to its effect in these rapid progressing children. And we performed a 3 years study where we showed that it is safe. We are still evaluating the results. We see some positive tendency of slowing the total kidney volume. However, I must say that the burden of drinking and peeing more than 6 liters a day, it's really, really very hard for children. And I don't think that we have there already the answer. However, we need really to consider some treatments for the very rapid progressor childhood that I showed you before. And we need really to work on stratifying our children and detecting the one with this very severe form of a DPKD. But I will highlight again, they are very rare, and I would like to mention this that the majority of the children are indeed doing well, and they will be not considered for using tolvaptan. So our problem in pediatric research is that we are confronted with actually a growing child with a growing kidney, and we don't have a lot of data on children to define our endpoint and to really stratify the children who are doing well and the ones who at risk with a rapid progression and reaching 8-stage renal disease at very young age. So together with Max Libaud and Franz Schaeffer, we initiated this ADPKD registry dedicated for children to assess our current management, but also really to define more international guidelines and recommendations. And it is an anonymous registry, of course, that we are entering all the data on the diagnosis, on the familial history from prenatal till actually 18 years of old. But however, we are trying to get at the study termination a connection with the adult registry to try to follow up this very special population and to see how they are doing it at later ages. And I am pleased to introduce Angélique Dachit. She is a pediatric nephrologist from Liège in Belgium, and she is actually doing an incredible work in analyzing the first results on a DPKD registry. The numbers are growing daily, and I think we are now already more than 1,300 patients. And as you might see, the whole world is participating with us. We are even collaborating with the UK Radar Registry, with the Kitchen Registry from Australia, and with the NIH Registry from Cystic Disease from US. And this associated database have actually decided to pool all the data and to analyze this with us, which will give us really huge information in the future. And I would like to share some preliminary data what we have, and these data have been analyzed from Angelique in April from this year. So as you might see, Europe is now very active in including patients, and we have in between reached already the 1,000 children. You can see the participation of the countries is a bit everywhere, and I must say that a lot of countries are awaiting for their ethical approval, but we have really a lot of centers who are joining us every day. So we have 51% female. As you can see, they are actually diagnosed at very young age, and we have few of them are diagnosed already prenatally. When we analyzed the reason of the diagnosis, and it gives me the opportunity to go back to our first slide, is that the familial screening, really active familial screening of asymptomatic children, is almost in 40% of the patients that we are following up in pediatric nephrology. Prenatal diagnosis is increasing the last years, 10%, and only 8% are really presenting with clinical symptom. So genetic diagnosis is made in almost 40% of the patients included in our registry, mainly, of course, PKD1 mutations. So beside the registry, I am working also in collaboration with Charlotte Gimpel and Franz Schäfer, and we might contact you soon via the PKD International, because the opinion of the patient is very important for us. And actually, we are developing a tool, patient-centered outcome, to analyze the quality of life of the children, to describe also their pain, anxiety, depression. However, we are actually making a questionnaire for the patient, for the parents, for the affected one and the non-affected one, and we are trying to explore the intrafamilial association of the disease severity and its impact. And this, we believe really that it will increase the physician awareness for the psychological impact in the young population with ADPKD. So to conclude, I think we made huge progress on understanding ADPKD children. We were able to write a consensus on the diagnosis and the management of ADPKD children. And the main thing to retain from my presentation today, even if you don't want to screen your child for having the disease, please at least screen for hypertension and proteinuria, and go to the GP or to the pediatrician just to measure these two parameters. And I would like to highlight for all my colleagues that the clinical testing of at-risk offspring is not a doctor decision, but it is a decision that should be discussed with the parent and with the child if he is mature enough. And the pediatric patients and their parents have really a particular need for support. And our project to explore this psychological burden is really, really very important in the future. And of course, I have a lot of hope that our ADPKD registry will be very important in optimization and standardization of the ADPKD care in this young population. And I would like to finish with the quote of one of the adolescents who wrote in the MapRoot that there is no decision about me without me. And I think that is very important to get this today. So I would like to thank all my PKD research group, but also all the collaborators that they are working with us to improve the pediatric care. I would special thank for Tess, who supported us several times. And I think my big thank is the children and their parents of my IDPKD clinic in Leuven. And here are kidneys made by these children when we organized a patient ADPKD in Leuven few years ago, where actually the parents were listening to the healthcare, and the children wrote a song, and then we end with the reception where all the children have this very nice song. And we did actually some workshop for the patient, highlighting the salt and highlighting the need of the sport. And here you can see Tess Harris was with us, and we were hoping to make this a tradition and to organize this. However, with the COVID, we are now all after our computer, but I hope that we can organize it this very soon again. And I will thank you for your attention, and very happy to answer your questions.
Thank you, Jalila. We've had a lot of very complimentary comments in the Q&A, and a few of the earlier questions you have in fact answered, to do with mainly the screening and testing in children. In the interest of time, however, I've just got one question that's come in from Poland, if I might ask you. So I'm going to ask you in English if you can reply in English. So this is somebody, the couple have wife has ADPKD, 12-year-old daughter. Is it possible to determine at what age they can assume it's unlikely she has ADPKD? She's asymptomatic now.
So could you repeat the question, Tess?
Mm-hmm. So the child is 12, yeah, asymptomatic.
Yeah.
What age can they assume it's unlikely she has PKD?
I think it is the age of 40 years, 40, if she don't have cysts, if they want to wait. However, in between, I think it is very important, as I mentioned, that they do the blood pressure to be sure that she don't have hypertension. And I think it is very important to discuss with her now, or when she is adult at the age of 18 years, and to make clear that she has a risk 1 in 2. Don't know if I answered the question, but
thank you very much. So I know you have to get back to your conference.
No, I don't know if there are other questions. I can.
I'll just allow one more, if I may, and then we'll move on to the next speaker, Jalila. So we had a question about screening for children again, and is there a specific cutoff point to diagnose hypertension? Is it lower threshold than the general population?
Yeah, so actually in the consensus paper, we are stating that the age of 5 years, because the work with Francesco Emma are highlighting the need of ABPM, so the blood pressure 24-hour monitoring, and there it is only available from the age of 5 years, and I think that is a threshold which is acceptable.
Thank you. That's it.
Thank you very much, Tess.
Thank you for joining us.
Thank you. Have a nice day. Bye-bye.
Bye now.